Pain is unpleasant sensory and emotional experience, usually characterized in terms of tissue damage, which is signaled by some form of visible or audible behavior. Attending to pain is highlighted as the fifth vital sign to monitor in medical care. Untreated pain may have long-term and permanent repercussions on pain sensitivity, immune functioning, neurophysiology, and healthcare behavior. It can affect all aspects of life, including appetite, mood, self-esteem, and the relationship. So let's see pain management in children. There are a lot of barriers for pain management in children. Some of the possible reasons for inadequate pain control in pediatrics are inability of young children to cooperate or provide good verbal description of pain, which makes pain assessment in children difficult. Misconceptions that infants can't feel pain or will not remember it, and also lack of education of healthcare professionals on pain, physiology of pain, pharmacology, assessment, and the management of pain. In addition, unfamiliarity of the healthcare professional with analgesics and the dosage and the fear of the side effects of the drugs, like respiratory depression and addiction, are some possible reasons for inadequate pain control. The other barrier is absence or unaware of pain assessment tools. Ways of assessing level of pain in children. Good pain assessment contribute to prevention and early recognition of pain as well as its effective management. But in order to assess pain, effective communication should occur between child, family, and the caregivers and health professionals. There are many pain assessment tools based on age and the cognition of the child. But the three fundamental approaches of pain assessment are: the first, physiologic pain assessment. Physiologic pain assessment primarily measures physiological arousal consequent to pain. This includes increasing heart rate, blood pressure, respiratory rate, autonomic symptoms like vomiting, sweating, but they are non-specific and they can be signs of other common childhood illness, so usually not used for pain assessment. Second is behavioral observation, measuring behavioral distress associated with pain. The third method is self-report, measuring expressed experience of pain. Mostly children who are less than 3 years old can't express their experience of pain. Whenever feasible, it is preferred to try to get the level of pain from the patient or the child, his or himself. And trust patient's pain, as pain is a subjective experience. It is the best and the golden standard approach, self-report. For children between 3 to 8 years, they can quantify their pain and are able to translate it to visual representation. Therefore, we use the visual along which quantifies pain based upon a series of faces in different phases of happiness and crying. Wong-Baker faces pain rating scale allows ranking the level of pain by observing the child's face. So this one is used for children from 3 to 8 years. For children 8 years and above, usually have a word for pain and can articulate more detail about the presence and the location of pain. Therefore, verbal rating scale can be used. This is categorical scale for rating pain based on the patient's description. The response range is none, mild, moderate, or severe. When we came to management of pain, an optimal management of pain in children begins with an accurate and thorough assessment of pain. Following the assessment, a treatment plan is developed, including pharmacological and non-pharmacological intervention. Non-pharmacological management of pain is a method used to decrease the child's fear and include the family into the therapeutic objective. They can be used alone or as an adjunct treatment to pharmacologic therapy. Some of the non-pharmacologic methods can be applied in children may include: the first is distraction. This is shifting the child's attention from painful stimuli. Example, looks to painting wall, pop-up books, or TV. The other is reinforcement, saying that he or she did a great job and giving stickers. The other is family member presence during painful procedure. The other non-pharmacological way is gentle reassurance and carefully chosen words to reduce fear and pain during procedure. Deep breaths or bronch bubbles, especially for younger ones, are some of the methods can use. Splinting, putting ice or elevation in dislocation or fracture, and also for newborn and infants, kangaroo mother care, swaddling, and using pacifier and sucrose will help in pain management. For localized procedure, local anesthetics such as lidocaine can be given. Local anesthetics may be administered by local infiltration or topically. For lidocaine injection, tips to make the injection less painful are to make it warm, to use smallest needle, and to buffer 10 to 1 lidocaine to bicarbonate and inject slowly. The other important anti-pain in young infants, especially in neonates, are sucrose analgesia or glucose analgesia. Administering 2 ml of 25% sucrose oral using a pacifier or a syringe decrease the pain during procedure. Apply 1 ml of this orally to each cheek 2 minutes before the painful procedure. Generally, glucose analgesia is safe and effective in managing procedural pain such as heel sticks and injections. It is effective in newborns and the effectiveness decreases gradually over the first 6 months of life. The other is pharmacologic treatment of pain. According to the severity of pain, WHO recommends treatment of pain in children in 2 steps. Step 1 is for mild pain. The medicine used are non-opioid analgesics like paracetamol and ibuprofen. Whereas for moderate to severe pain or step 2, strong opioids are used, such as morphine. In general, opioids should be administered at regular intervals and not on as needed basis. Oral administration of opioids is preferred. Treatment with strong opioids need to be individualized, and there is no fixed maximum dosage. It should be individually adjusted. So overall, for mild pain, most of the time, non-pharmacologic managements are adequate, but sometimes non-opioids can be used. For moderate pain, non-pharmacologic management plus non-opioids such as paracetamol and ibuprofen is used. But sometimes for more severe one, opioid is also used. When we see the dosage for non-narcotic one, in opioid 1, acetaminophen 50 mg per kg IV or PO. Ibuprofen is also 10 mg per kg PO. Morphine is most of the time 0.05 to 0.1 mg per kg IV. Fentanyl is 1 microgram per kg IV. And always it's better to avoid iron medications because they are painful. This is a summary of pain management in children. Thank you for watching.